Okay, so welcome to the Topics in Rehab Science presentation for the month of January. Thanks for joining us. It gives me great pleasure to announce our speaker for today, who is Dr. John Whyte. Dr. Whyte probably needs little introduction or no introduction to most of you. He is the founding director of Moss Rehabilitation Research Institute, and he continues in his duties here as Institute Scientist Emeritus. Dr. Whyte received his MD and PhD in cognitive psychology from the University of Pennsylvania and completed a residency in physical medicine and rehab at the University of Minnesota and a TBI fellowship at Tufts University. Dr. Whyte, as many of you know, is a leader in traumatic brain injury rehabilitation, and in particular disorders of consciousness. He was the founding director of the Clinical Responsiveness Program at Moss Rehab and has been involved in national and international collaborations on coma recovery. In addition to an established scientific leader, Dr. Whyte has also served as mentor to numerous budding researchers at Moss Rehab and beyond, including the training of many successful physician scientists. Most recently, he has pioneered the development of a classification system for rehabilitation treatments to advance the science and practice of medical rehabilitation, and that is what he will be speaking on today. His talk is entitled Implementing the Rehabilitation Treatment Specification System, known as the RTSS, in Research and Practice, a case study from Speech Language Pathology. So please welcome Dr. Whyte.
Thank you very much, Umi, and thanks everyone for attending in person and remotely. As Umi mentioned, well, first of all, this is one of the Shrier family topics in rehab science, and we're very grateful for the sponsorship of Marc and late Nancy Shrier. There is CME credit, and this is the code number that you'll need to obtain that CME credit or CEU credit. The disclosure statement. I'm going to talk about obstacles to implementing the RTSS in research and practice, and also some of the specific ways that we might solve those obstacles with relationship to targets and ingredients in rehabilitation. And I'll be defining those terms more as we go along. Now, a couple of disclaimers. As mentioned, this RTSS has been in development for more than a decade, and many of you are familiar with some of its concepts. I'm not going to have time to go into the guts of the RTSS itself today. And so I'm going to do just a fast review of some of the key concepts, because today's talk is focused on what it will take to actually implement this in use in rehabilitation and what some of the challenges and strategies might be. Secondly, I'm talking in this presentation about work that's been done in speech language pathology. I'm not an SLP myself, so I might get a few details wrong, but I'm really presenting the big picture, and I think I'm beginning to get a little bit of a honorary SLP degree from the amount of time I've spent collaborating on these projects. So first, the very brief review of some of the concepts of the RTSS that you'll need to understand the issue of implementation. So remember, this project was launched to try to address a big problem in rehabilitation that we refer to as the black box. The black box problem, meaning that we have names in rehabilitation like cognitive rehabilitation, gait training, inpatient rehabilitation, physical therapy, that we throw around, but that don't clearly map onto any particular treatments or ingredients that you could replicate or say, oh, this works really great, why don't you do it too? Do what? Physical therapy? So that's the problem that we set out to try to address with the RTSS. And I think that the RTSS has chipped away at this name problem, but we haven't completely solved it, as you'll see. Now, another concept that you need to understand is targets. This is a term in the RTSS where we divide up a treatment, which is often a complex treatment that does a lot of different related things, into a set of clumps, each of which is trying to change one specific thing. So you can imagine that if you were trying to treat someone's depression, You might have the medication that's designed to alter their mood, but you might also have education that is designed to make them willing to take the medication. You might have ingredients like an alarm clock or a pill box to help solve the problem of remembering to take the medication. So you have all these pieces that are all in service of getting you less depressed, but different pieces accomplish different sub-purposes of that larger goal. Each of those sub-purposes, a specific thing that a specific set of ingredients will change, is called a target. And so we clearly need to identify what targets our treatment is addressing. But the problem is, we said, okay, I've got this target, this target, this target, this target. What do we call those targets? Okay, we'll come back to that. Similarly, the RTSS focuses on defining ingredients. The ingredients are the things that we deliver to patients in one form or another, intending to change that target that we just identified. So this can be information, it can be physical objects, it could be medications, it could be energy, it could be all the different types of things that we introduce to patients in rehabilitation to change a target. In the logic that I just described to you before, we're going to sort those ingredients into these are the ingredients that address target A, these are the ingredients that address target B, these are the ingredients that address target C. Why do we need to do that? Well, think of it, think of a cooking analogy. If I told you we're going to have dinner tonight and here are all the ingredients for dinner, should we just dump them all into one pot? Or I could say, we're having dinner tonight and we're gonna have a salad and it has these ingredients, and a soup and it has these ingredients, and a dessert and it has these ingredients. We'll probably get a better dinner that way if we associate specific ingredients with the specific targets of our treatment. But what do we call those ingredients? Okay. So think of the RTSS not only as a scientific organizational framework, but as a communication system. So the RTSS can already support individual researchers and clinicians to rigorously define their interventions based on these concepts that I've just talked to you. So if I'm inventing a new treatment, I can divide it up into different treatment components. I can tell you in my words what those targets are. I can tell you in my words what those ingredients are, and we'll be very clear on what I'm doing, presumably. But now, if we have two researchers or two clinicians talking to each other, this gets a little bit more complicated. Because now we require a shared language for names of those targets and names of those ingredients. So if I say I'm treating muscle torque, and you say you're treating muscle strength, are we treating the same thing but using different words for it? Or are we actually treating meaningfully different things? And that's a really important unresolved question that our system needs to address. Because we might want to do things like aggregate all the studies that have treated muscle torque. Should we include the studies that have treated muscle strength? You know, we have to make these kinds of decisions. So we have a problem in what's referred to as ontology, a shared set of terms and a shared understanding of how those terms relate to each other. We can each have our own set of terms that obey the RTSS logic, but we still won't know how those terms compare to someone else doing similar work. So what I'm going to be talking about today with introduction is some interrelated projects that have tried to solve this sort of nomenclature and consensus kind of problem in a very small domain. So this work was done in collaboration with my colleague Jared Van Stan, who is a speech and language pathologist who specializes in a very specific area of speech language pathology, voice therapy. He's actually a former opera singer, as quite a few voice therapists are. And so he treats singers who have problems with the quality of their voice, as well as regular non-singers who have hoarse voices or rough sounding voices and so on and so forth. And I'm going to talk about a clinical problem referred to as muscle tension dysphonia. It's a common disorder of the voice, and it is this problem where your voicing is doesn't sound good, it feels effortful, sometimes uncomfortable, and so on and so forth. The advantage is that this is a narrow domain where we don't have to consider 100,000 possible targets, we consider a smaller set. And there's a relatively small set of people who are expert in this area that we can talk to and get consensus information from. Importantly, for this first project, there already exist, I think, 8 different published evidence-based treatment protocols for muscle tension dysphonia. They're called this person's treatment protocol, that person's treatment protocol, that person's treatment, but they all have undergone rigorous testing and showed that they are better than placebo at getting people, not placebo, but better than alternatives at getting people better in terms of gross outcomes like vocal quality of life and stuff like that. Okay. Now, muscle tension dysphonia is an imbalance in the coordination of the muscles and breathing patterns needed to create voicing. It can be primary, i.e. it arises for no clear reason, or it can be secondary after you've had a nodule or some kind of injury and then it develops. And it results, as I mentioned, in abnormal vocal quality, fatigue, neck discomfort, and so on. We have multiple protocols that have been supported by randomized controlled trials. But what we don't know and what we can't know is, are these protocols that are all effective similar or different? What does that question mean even? Because we don't have standardized names. So we're back to ontology again. We have 8 protocols named after human beings that are themselves black boxes in terms of their ingredients. So Jared, with some help from me, tried to address this problem by engaging in a modified Delphi project. If you're not familiar with that, it's a structured way of getting consensus from a group of people. It involved rounds of sending things out, getting people to endorse them or not endorse them. And if they don't endorse them, they criticize why they didn't. And then you massage the text and send them out for another round to the point where you get usually 80% consensus. And then you say that's good enough. Jared used this approach. He recruited 10 voice therapy experts, some of whom were authors of some of those protocols, from 8 specialty voice clinics around the country, a couple of experts in the RTSS, me and him, and one other speech language pathology expert who was not a muscle tension dysphonia guy. And we had 3 Delphi rounds trying to agree on a finite set of targets that voice therapists treat, and 3 rounds on the ingredients that voice therapists use to treat those targets. So what we're trying to do now is get everyone to agree on what the smallest set of targets needed to describe their practice is, and what the smallest set of ingredients that they use to treat those, and then to agree on names so that we can all communicate about them, okay? But what we have to do in the process is explore these labels that people are using and ask whether they're unique or redundant. In other words, if we have 2 different names for possible targets and they're clearly unique, they're 2 targets. But if they're kind of, well, are they, or are they maybe redundant? Maybe that's really only 1 target and we need to pick the best name, okay? So we want to collapse everything that's redundant into the smallest number of unique things, so we have our minimal number of building blocks for targets and for ingredients. So we started with a list of terms for potential targets and ingredients from an extensive literature search of all the MTD treatments, and we sorted them into targets and ingredients. And then for each of those, we asked our participants, do you use it, do you treat it or use it? And is it observable or measurable? Because both targets and ingredients have to be observable and measurable. Is it overlapping or redundant with any other terms that are on this list? If so, and how and in what ways? And is there anything missing from this list that you need to cover your practice? Okay, so that was kind of the process. But importantly, we had to invent some probe questions to help people address what it means to say 2 things are redundant or unique. And so I thought these questions were really kind of interesting that we had to come up with. So let me give you an example. We ask people, if you ask people, are strength and endurance unique or redundant? People have a tendency to say, well, they're redundant because every time you exercise, you improve both. Okay, but every time you do a lot of things, you have a lot of effects, and that's going to get us quickly into trouble. But if you ask this question, you get much more precise. If you wanted to improve endurance rather than strength, or you wanted to improve strength rather than endurance, is there anything you would do different? If the answer is no, then they're redundant, right? If you treat them exactly the same way. But in this instance, that's not the case. If you want to maximize endurance, you do lighter weight exercise for more time. If you want to maximize strength, you do heavier weight exercise for less time. So you can tune them in one direction or the other. So those, by that analogy, are not redundant. They are unique. Also, we might say, you know, if you're familiar with targets and aims, is this something that you treat directly, or is this a downstream effect of something we treat? Well, if they said, okay, it's a downstream effect, we don't treat it directly, still we need to ask, but is there any other treatment that treats that directly? Because something might be a downstream effect of one treatment and a direct effect of another treatment. So we have these various kinds of probe questions that helped people arrive at consensus around what was unique and redundant for targets. We did a similar process for ingredients. If you used ingredient A versus ingredient B, would you predict any different effects on the target? And does this ingredient share any mechanism of action with one or more other ingredients? And if so, how do you choose among them? And let me give you an example of this one, which is kind of interesting if you're a voice therapist. So it turns out that a lot of treatment of muscle tension dysphonia involves doing things that increase the air outflow pressure while the patient's trying to talk. So you ask them to blow bubbles in water, or speak through a straw that constricts flow, but various things that make more resistance to outflow, and that helps, I don't know, somehow change the pressure dynamics and improve voice. Okay, well, is soap bubbles and a straw and a this and a kazoo, are these all different ingredients? Well, no, as we talked with our experts, these are all different gizmos that you use to alter the pressure. So really our ingredient is increased outflow pressure. We have a bunch of devices that we can use. If we wanted to get more precise, we would probably find that straws exert more pressure than kazoo. You know, we could arrange them in order of pressure. And importantly, sometimes we could say, these three gizmos are exactly the same, but I have this one in my drawer, or my patient likes that one. All right. So we have things that we can choose because we like variety and convenience and cheap, but we have things that we choose for scientific dose-related reasons of the ingredient in question. So using this iterative process with these probe questions, we started with 29 initial target labels, and we reached consensus on observability or measurability easily. It took a lot more work to reach consensus on unique and redundancy and a lot of restructuring, but we ended up with 15 new labels created for missing items, resulting in a total of 35. So we actually went up from the original number, but dumped a bunch of the originals and added some missing. Okay, but now all of these arguably are unique and operationally defined, different from any other item on the list. Similarly, in terms of the ingredients, high agreement on observability and measurability, less agreement on uniqueness, but we ended up here collapsing and recategorizing into a smaller number of categories, 19 final ingredient categories, reflecting that many of those gizmos really turned out to be one ingredient with gradations, if you will. So this is just an example of the kind of process you could use with an expert group of clinicians or researchers in a given domain to arrive at labels that could now be used and other words eliminated from the vocabulary, right? Because these arguably cover the domain. So where does that leave us? We have these 35 targets and 19 ingredient labels. They now compose a catalog called the RTSS voice. So that's part of the RTSS that covers voice therapy. So in principle, then all actions of all voice therapists following all therapy protocols could be captured by defining which of the 35 targets they're treating and which of the 19 ingredients they're using and how much of them in treating them, keeping in mind that we might still discover gaps of targets or ingredients that our consensus group didn't discover yet. So now I'm just going to talk briefly about two follow-up projects that are now exploring the impact of the RTSS voice. What happens if you can arrive at a closed set of terms that people can use? Okay, and so we're going to talk about two further projects. One is an attempt to compare those 8 protocols that I told you about according to these unique ingredients and targets. And the other is actual observational research on voice therapists in practice and what they're really doing during the session. So I mentioned that there are these 8 published protocols for muscle tension dysphonia, all of which have randomized controlled trials supporting their efficacy. But they all have been tested against macro aims, downstream things like vocal quality of life. So we know people feel better after the treatment in general, but we don't know, are you less hoarse? Does it feel less fatiguing? We don't know exactly what led to that. Now, I would say also testimony to Jared Van Stand's politics is that he has reached agreement with the authors of all 8 protocols to re-specify their protocols in RTSS voice terms so that we can ask the question, how similar or different are they? I say political because right now everyone has their name attached to a protocol, but I'm guessing that in some future time, we'll have 2 protocols that are hybrids because it'll turn out that there was that much redundancy and all those people are going to lose their names. Sorry. But anyway, he did get them to agree to that. So it's an iterative process where Jared reads through the published protocol, attempts to specify it in RTSS terms using those target and ingredient categories, meets with the protocol developer to go through it. They say, no, you didn't get it quite right. And so it's an iterative process until the protocol developer believes that it accurately represents their protocol and the RTSS person feels that it accurately follows the RTSS voice. So that's so far only been completed on 4 of the 8 protocols, so we don't know the full story, but I want to just give you a sense of the potential that this kind of holds. So let's think about what this study in the end could find. Suppose we find that 2 protocols treat the same targets with the same ingredients. Do we want to compare them in a comparative effectiveness trial? That would be ridiculous. They're the same protocol with 2 different people's names on them, and presumably the name of the protocol does not change its efficacy. So as soon as we know those 2 things, we're done. We don't need to do any research on them, except to give them a new composite name and be done with it. Suppose that we find 2 protocols that address the same targets using different ingredients. Okay, now we're really in a good position for a comparative effectiveness study. If you want to change this target, is it better to use these ingredients or those ingredients? Very good question. Suppose 2 protocols share a set of targets, but differ on some other targets. So imagine that we do the same practice in both treatments, but in this treatment, we do a lot of education and counseling as well. Might it be that that makes a difference in how things pan out? That's a useful question. And supposing this treatment improves your quality of life by improving your voice, the way your voice sounds, and this improves your quality of life by making you not care so much how your voice sounds, right? I mean, it's possible that those give you the same quality of life, but they have really different roots to that quality of life. That's worth noting. So the point is that right now, people are doing comparative effectiveness studies comparing MES A with MES B. without knowing how much of the mess is overlapping. And that really doesn't make sense in terms of an efficient way forward. So hopefully, when this process is done, we will at least know what are the useful empirical comparisons that are worth making in the field of voice therapy. And very likely, we might end up with muscle tension dysphonia meta protocol, which it's intended to improve vocal quality of life, but there would be a menu of potentially relevant targets. If you have pain, you should have some more of this. If you have fatigue, you should have more of this. If your voice sounds crummy, you should have more of this. If you feel unconfident about speaking in public, you should, and so now we can vary how much of different treatment components we give to different people depending on some sort of assessment. But we have a coherent understanding of what each clump of the intervention is intended to do. And they can be titrated somewhat independently. Okay, so now let's go on to the last project that has been sort of moving this line of work forward. And that was led by Jeremy Wolfberg, a grad student of Jared's, which is now using this system to try to understand what goes on in real world voice therapy and how voice therapists differ in their practice one to another. Because of course, they're not following, they're not in research protocols, they're not minutely following a specific research protocol. They may be mixing and matching among these 8 protocols already for all of them. So the question that Jeremy took on was, can the RTSS voice be used to characterize similarities and differences in practice among voice therapists as a prelude to exploring potential effectiveness? So if therapists don't do anything different, there's probably not much point in asking whether they have different results. If they do something different, it'd be useful to know what they do different, because that'll give us a better idea of what results we might expect to see different across those treatments, right? So in this study, they recruited 5 voice therapists from different institutions, and those 5 voice therapists each filmed 1 therapy session for a given patient across. So there are 59 patient treatment sessions, 59 patients, but obviously approximately 10 or 12 per voice therapist. This tends to be a relatively short course of therapy, but some patients have longer. So they tried to get about a third of the sessions from early, middle, and late, depending on the duration of the therapy course. Each of those sessions was observed by Jeremy, and he did start-stop times on the video for when the therapist was addressing each target and what ingredients they were using to address each target. And then those were reviewed by me and others for reliability to see whether we agreed on what they were working on and so on and so forth. And until we reached treatment consensus on all the transcripts of those video coding sessions. Now, in terms of looking at the results of what people did in those sessions, some targets and ingredients were very commonly encountered across all therapists and all patients. And that's not too surprising. It's a relatively narrow domain of practice. There's a lot of agreement on what you should do. The targets that were most uniformly addressed by the clinicians were increased volition to perform activities at home. In other words, all of these treatments involved some sort of homework practice at home, and all of the therapists spent a fair amount of time instructing in what that home practice should be and giving motivational messages about the importance of it. The other target that was most frequently addressed was decreased strained vocal quality. So directly doing things and asking, does your voice sound better as a result of doing that, and practicing those things. In terms of ingredients that were frequently used, lots of information regarding the patient's capability and motivation. So a lot of coaching on, you can do this, you're doing a great job, you have done this, you did a great job this week, you need to keep doing it next week. A lot of use of knowledge of results. So, you just voiced that sounded better, that sounded worse. Did you hear the way that sounded? That sort of thing. And then a lot of opportunities to practice voicing with improved resonance and mean airflow. In other words, this is where we're going to practice, but you're going to be blowing through a kazoo, or you're going to be doing something that is changing the airflow while you practice. And this parenthetically resulted in another development, which is the notion of a practice template. In the skills and habits category of the RTSS, the category which covers so many of the targets that we work on with patients, where we try to teach them skills, dressing skills, walking skills, cognitive skills, et cetera, we have said right from the beginning that what the key ingredient in the RTSS is opportunities to practice, right? That's the thing that is required to make that thing better. But what are you practicing? We have to tell you, I want you to practice this. I want you to practice it this way, right? So this is the notion of a practice template. I, as a clinician, have to design the behavior that I now want you to attempt to replicate through practice. But I have to say, I want more airflow while you practice. That's the practice template. And if you didn't get more airflow, I'm going to say, try that again. We got to improve more airflow with practice, et cetera. So practice template is something that you're going to see in kind of any skills and habits situation. So those are the things that were most unique, most uniform, most consistent. But there were also things that varied a lot from therapist to therapist and patient to patient. The types and number of treatment components introduced. So some therapists just did strained voice and pump work, and some people did other things about modulation of your voice and improving your volume and so on and so forth. Types of feedback varied. Some therapists relied much more on them giving you feedback. That sounded better, that sounded worse. Others used much more, what did you think? Did that feel better? Did that feel worse? What did you learn from that? So that would be a useful empirical question. Does it make any difference whether you give the feedback or you elicit the feedback? Also, whether vocal practice was within spontaneous speech or structured voicing. This is another comparison that's probably really of interest. Do you give people, do you say or do you say, I want you to go while you're having a sentence, right? Those are really different ways of practice, and it might make a difference. And then some therapists use what's called negative practice quite a lot. They believe that when you have muscle tension dysphonia, you've sort of fallen into a little habit pit that you can't get out of. And we get you out of the pit and get you back into a better voicing pattern. But you might have a recurrence. And so I want you to know how to climb out of that pit and how to climb back into that pit and how to climb out, how to climb back in, so that you are now a master of both of these, and you're going to choose to use the good one. But I give you the confidence that you can stay in the good one by teaching you how to move back and forth between the two. Okay, so that's a thing that some therapists did and others didn't. Importantly, there were no new targets or ingredients needed. It was the case for these sessions that the existing RTSS voice covered all of the things that needed to be documented. So again, an example of how we could use, once we have created the categories and the definitions, we can now use this to ask meaningful questions about practice variation. And as you can see, where we find variation, we can think of logical ways to ask about what it might do. And where we don't find variation, we could say, let's not try to examine comparative effectiveness of two things that are the same. Okay, so just that's the sort of the end of my review of kind of the empirical work that's been going on recently in voice therapy around advancing the RTSS. But let's just reflect a little bit on the next steps, which are somewhat daunting. First of all, within an individual study like this one, we can develop hypotheses about how outcomes might differ based on those areas of variation, right? How might method of feedback change things? And now I have some interesting study aims. We could also explore dosage or intensity variations in the dimensions that have the greatest overlap. So even when people all do the same thing, do they do the same amount of that same thing? Is a question we haven't yet looked at. But what does all this have to do with you if you don't treat muscle tension dysphonia? And I'm guessing most of you don't treat muscle tension dysphonia. Well, I hope that I will convince you that these are some very general lessons. In terms of comparison of comparative effectiveness research, almost all rehabilitation treatments can be considered complex treatments, meaning that they're a collection of treatment components like a multi-course meal, not like one big stew. And they address a common big picture, but it's almost always the case that there will be some overlap between two complex treatments because they have so many parts and so many ingredients. Just as we saw quite a bit of overlap across the 5 clinicians and patients. It will be more informative to make targeted comparisons of the areas where we see differences than to sort of make a global comparison of the whole stew A to stew B. Now, if across all rehabilitation treatment domains, we could agree on a finite set of targets we treat and operationally define them, and we could agree on a finite set of ingredients that we use to treat them and operationally define them, then we could use those defined categories to compare existing treatments, as is being done with the muscle tension dysphonia protocols. We could then do more efficient and intelligent comparative effectiveness research. We could use those defined categories to compare naturalistic clinical practice, as Jeremy did, to facilitate supervision, to consider quality improvement efforts. How come you're not delivering as much of the ingredients as they are? What can we do? And we can use those names in EMR documentation so that now the medical record could begin to really be supporting a learning health system in rehabilitation, which it hardly can do now, at least in terms of the therapy disciplines. But so that's a wonderful and grandiose vision, which I'm grandiose enough to hold, but here's the challenge, and it's a very big one. Who's gonna divide up the domains of rehab to assign them to the different groups of people who are gonna arrive at the targets and ingredients? Who's gonna identify the stakeholders? Who's gonna be responsible for gait training? Who's gonna facilitate the process that we had of probing for the redundancy and the uniqueness and sort of facilitating that through in a standard way across experts in a lot of different domains. And these are not going to be permanent classifications, right? We're going to have empirical research that says, oh, I have a new ingredient, or that target is really 2 targets after all. We're going to need a system for adjudicating changes in terms and definitions as the science changes. Will we need something analogous to the ICD manual, which is a worldwide manual, and who will develop that? So it does seem to me, the more I think about it, the more we're going to need some big picture infrastructure if we want to go beyond the conceptual benefits of the RTSS to the operational benefits and the communication benefits. I don't have a clear sense of how we're going to do that. It's an incremental thing, but stay tuned for a couple of upcoming additions. Shirley Ryan Ability Lab is, believe it or not, redesigning their electronic medical record to conform to RTSS principles, and they're already having to address how do you get speech pathologists, physical therapists, and occupational therapists to use the same terminology around volition and motivation and stuff, which needs to be cross-cutting already, and we're just within an individual institution. But they're doing a really interesting pilot that's going to tell us a lot about the challenges involved in developing these terms and this EMR system. And then we're holding a RTSS Super Users Summit here in April, bringing together 45 individuals who have the most experience so far in attempting projects with the RTSS. We're going to bring them together to network with each other and also to help us problem solve these cross-cutting infrastructure things that will be needed if things are going to move forward. And I think that's all I have to say. I will be happy to entertain questions or discussion. And how do I know if somebody elsewhere is? Should I pull something up?
Anthony, if there's questions in the.
Yeah.
And then is there? Oh, can I get rid of this so I can see people again? And then. Oh, and show that would. All right, now I can see people, and if anyone wants, Amanda in the room has a comment.
Thank you. Very, very interesting and great that there was a relatively circumscribed field to kind of serve as a pilot to test out how applicable some of these RTSS principles are. I was wondering, so John, I think that you said that the vocal therapy exercise arrived at 19 distinct ingredients. I was wondering, since so much of what we do is in the skills and habits domain, and those volitional ingredients are incredibly important for getting people to practice, what proportion of the ingredients identified fall into that volitional ingredient basket versus the more domain target specific types of ingredients?
Yeah, I don't think I could give you a count without going back to the catalog, because they're such unfamiliar terms to me. There were plenty of more voice specific things. There are ones about practicing different breathing rates, different manipulating your neck while you're voicing. So I just went into stuff that I understand, but I would say if I had to guess, 1/3 volition, 2/3.
Because that would potentially be domain generalizable
Right.
across any type of practice.
Yes, indeed. Yeah, if you can envision a process of arriving at a finite set of terms at all, which is a challenging process, I at least can imagine that some of those terms would be developed by smaller groups that really do kind of own a domain, but that volition, we're going to have to figure out some process that brings in psychology, all disciplines and psychology, because it has to be acceptable to all of these people. And I think based on that article that we just circulated recently, which other people don't know about, but the issue, particularly in psychology, is that there are 100,000 names that no one can no one for sure has done the exercise of saying, are these two things redundant or unique? But I don't know that you even could, because they're big, complicated, multifaceted, like self-efficacy and locus of control. Okay, are those different? So, yeah.
Yeah, I agree. I think this is a great framework to look at, especially rehabilitation treatments. I'm curious though, how the framework deals with things where like there's different causes for I forget what the name of this problem is, this vocal
Muscle tension dysphonia.
Yeah, so there's different causes for it, but you could imagine situations where certain causes for that problem are treated better by one therapy versus, or one way of doing something, like the feedback thing. Like maybe it's caused by some sort of neurological disorder where they can't learn in a certain way. For example, like how would the framework deal with those types of things?
Yeah, okay, so first of all, can people online hear the questions? I'm not sure how the sound, or yes, okay. Well, first of all, I think, and again, I'm not a muscle tension dysphonia person, so anybody who knows more than me, feel free to correct me, but I don't think that's the kind of secondary that they're talking about. I don't think it's a neurologic, it would be, you had a nodule, the nodule was removed, but your voice didn't automatically get better. And now the notion is still that while you had an anatomical perturbation, you learned bad habits that you now need to alter. So as far as I understand, the treatment of primary and secondary are thought to be the same. That doesn't mean that we couldn't still ask the question empirically, if you had prior surgery for nodules, is protocol A more effective versus if you didn't? But even that question wouldn't be worth asking if protocol A and protocol B are the same. Like, then they're gonna be equally good for everybody because they're equally good.
Right. I guess I'm thinking more of like from as a PT from a gait perspective, like gait dysfunction can be caused by any number of neurological problems, but those might be treated differently depending on what that neurological problem is.
It's true, but keep in mind that they also might not be.
True.
Right, I mean, because this is, I think this is one of the things that has kind of vexed rehabilitation to some degree is that we can't quite make up our minds how relevant the etiology of a problem is for our addressing it. And we spend a lot of time trying to understand the etiology in hopes that it will inform the treatment, but there are also plenty of treatments where, you know, if you're gonna do cognitive behavior therapy, you know, I mean, it's kind of it doesn't ask, how did you get this way, right?
I mean, I would also say that, I mean, the specifics of the RTSS would say that you have to think about that specific target you want to have and how you're going to frame that, and it's not going to be generally improving gait, but you have to think about a specific aspect of gait that you want to change.
Right, you might pick different targets for a neurologic gait disorder than for a arthritic gait disorder. Yeah. Yeah, let me.
Sorry if you talked about, sorry, but did you talk about, like dose?
I didn't talk about dose
Or
much.
how you reach consensus on, because if you're gonna have this meta protocol, they would have to agree on dosage and treatment schedule.
Yeah. So dose is something that the RTSS has, I think, made progress in, but there's still more work to do. So first of all, first thing we would say is duration of session is not a good dose metric. Let's stop using that, which is kind of used universally. Second thing is there are things that don't make sense to talk about doses at all. So once I give you a piece of information and you have it, giving it to you 2 or 3 more times, if you already have it, won't do anything, et cetera. But importantly, the RTSS asks you where dose is relevant to frame dose in units that are relevant to the mechanism of action. So if it's radiant energy, it's going to be energy units. If it's practice, it's going to be something about the practice schedule and so on. So if we were comparing, let's say, 2 clinicians working with different patients, if they were doing things that don't have doses associated with them, then of course we wouldn't be able to compare. But if they're practicing voicing with better airflow, we could ask whether this one did more trials than that one, or arrange their trials separately, scheduled their trials differently, or sent them to do more home trials, or any of those dose-related things. Is there anybody online who wanted to ask anything in case I've been ignoring you? Oh, Teresa.
Hi, I just had a question. It sounds like most of the data was collected through getting information from these providers. And then you also talked about the Shirley Ryan lab trying to access information from the medical chart. So I guess more of just a point of, it seems like it's a common language that we're missing. And then how could we structure that language once these terms were committed to, in terms of getting it out to utilize it for, so that we're all utilizing the same language? Or, you know, I'm thinking about like students and of what they're learning in school. It feels like everything we learn is in pockets and you don't get that experience until you're actually out there. So how could we get this information out sooner?
Yeah, I mean, it's a good question, and I can't fully answer it because we don't know the answer ourselves, but I mean, we can't get the terms out there until we have the terms, right? So my belief is that the first step, I mean, we're already at the point where the conceptual value can help people think clearly. It's just that it doesn't resolve this last ambiguity problem. But with respect to that, I think the first step is for us to find ways to arrive at these finite sets, whether that's done in small areas of practice like we just saw, whether professional societies could be persuaded to take this on in some fashion. But that's the big lift, step one. The EMR thing is really step two. I mean, surely Ryan is looking at this in principle, but in order for us to use kind of traditional big data analytics from the EMR, it would be a lot better if there were specific terms that had consensus meanings, obviously, just as we have for medications or various kinds of medical diagnoses or whatever. So what we would want, once we have agreed upon targets and ingredients, is then to probably have sort of drop-down menus in EMR so that clinicians don't have to remember all the terms, but they have to pick from an allowable list. What is it you treated and what did you treat it with? The other thing that I'll just say briefly is that another thing we have to settle on is what's the level of granularity. So when I'm a researcher and I'm specifying a protocol, I mean, I can spend hours specifying one 30-minute session that I'm gonna do in a research study. If you have, 10 patients a day doing multiple activities, you can't do that. So we're gonna also have to play around with what level of detail you chop your treatment up into for the EMR, and it's probably not realistically going to be the same level of detail as a researcher would need to use.
And I feel like currently there is, I don't know if there's any treating clinicians right now, but on inpatient, I feel like they're collecting the same type of data across the board, because I know a lot of staff who work inpatient and outpatient had to learn a new system of trying to quantify what type of environment the person is being treated in. Was it noisy? Was it loud? To try to collect more of that data.
Right. I think those are the Care for TBI project, that's an interesting point that you make. That's another project that is trying to systematize the EMR a little bit more, but really going at it from the standpoint of categories that are kind of more in everyday use.
Right.
Queuing and noisy environment and so on and so forth. But, whether those would be adequately operationalized for our terms, I'm not sure. Because they're really things that we start off by saying, here's what clinicians are already doing. Can we tweak it slightly and make it available?
That was trying to capture and harmonize across different systems, terms that are already commonly used and not imposing a common language. So allowing people to use that variability as long as we can sort of map it onto, these are roughly the same thing. But this to speak to the point of what it would mean to get this in practice, I think transforming the EMR to enable that is important. But infusing it in training curricula and having ongoing training and support, because just because there's a field in the EMR doesn't mean that anybody is going to use it, in the intended way. So finding ways to make sure that that system also works for clinicians and is a benefit, and there's ongoing training and support for using it properly is a lesson we're already learning in Care for TBI.
We're 2 minutes over, but I see that Shailesh has a question, and if I can try to answer it quickly.
So I think I'm just going to kind of, because education came up twice, I'm kind of going to give a little bit of my experience. I think the main strength that I have found in sort of using RTSS when educating clinicians is where it sort of makes you think beyond clinical practice guidelines and think in terms of what is the target that I'm trying to target in my intervention, and that kind of leads to a greater, a more thorough evaluation, as well as a better understanding of what exactly are you doing in therapy. Much more than just.
Yeah, and that doesn't require that we have a standard set of terms, because then I can say
True.
what I think and so on. Yeah, so I think that's.
But I think having a standard set of terms also makes students a little more comfortable, especially when you think about professional education and those kinds of things. Having a common term really helps.
All right, well, I think we should let you all go back to your lives, and thank you very much for joining me today.